Thank you very much, and good morning, everybody. It's a real pleasure to be here this morning. In fact, it's the second time this week I've been in this room. I spent all day Tuesday down in this bunker under the ground with my own team, so good to be back twice in a week. The NHS celebrated its 70th birthday last year, and I'm sure you're all aware of that. And it's almost another anniversary coming up, actually next year. It's almost 30 years since Douglas Black published his seminal report in 1980, which looked into inequalities in healthcare. And it's worth reflecting back on that report, which really set out the map, if you want, for inequalities. And think about where we are 30 years later. So I'm going to quote here from Nick Timmins' book. Some of you might have read it, The Five Giants, The History of the Welfare State, because he quite nicely and succinctly describes that report. So the Black report showed unmistakably that the death rates for many given diseases were higher for the lower social and occupational classes than for the higher. And that while death rates for social classes 1 and 2 had improved over the 20 years up to the early 1970s, those in the lower social classes 4 and 5 had changed little or had even deteriorated. Overall, the standards in 1980 of health had risen, but despite the NHS and despite the welfare state, the health gap between rich and poor seemed to be growing. This was terribly explosive stuff. The difficulty was that Black and his group concluded that the NHS had little to do with this state of affairs. More emphasis should go on prevention and primary and community care, but many of the key causes of the gap inequalities, so far as they could be established, seem to lie in issues such as income, work, or rather lack of it, environment, education, housing, transport, and lifestyles. So 30 years on, I think that would paint a very familiar picture. During my last year, my first year as medical director of NHS England, I've taken papers to the board of NHS England on 2 occasions, which look at the position, current position, regarding inequalities in access to healthcare and in healthcare outcomes. The first really to set the scene and to describe the current position, and the second to start to describe what we are doing and what we possibly can do in the NHS to assist. And the truth is that 30 years on, we still see those same problems. In some areas, in fact, the gap in inequalities is growing bigger, and I am sure that is something that you are well aware of and that many other speakers this year and in previous years will have highlighted. Not where we want it to be. And it's also true, as it was 30 years ago, that many of the drivers for inequalities come from outside health and from outside things that the NHS has a direct influence over. So it is still housing, it is still the economy, it is still the ability to get work. That is as true as it was then. But I don't believe, and I don't think NHS England believes, that means that there is nothing that we can do. In the NHS, we have a responsibility and an obligation to contribute to addressing those inequalities wherever we can. And although we cannot do that alone, and we need to do it with our partners in social care, in public health, and across government, there is nevertheless things that we should do. I'm particularly interested in cardiovascular disease, and that was the area that I led in the long-term plan that I'll talk about. And I'll just give you a few examples, some specific examples in cardiovascular disease, which is one of the biggest killers in the UK, as to what that means in terms of deaths. So 7 million people in the UK are affected by cardiovascular disease. And as I said, it accounts for about 43% of deaths amenable to healthcare. And it drives a life expectancy gap as the largest cause of premature mortality in areas of deprivation. So premature death rates from cardiovascular disease in the most deprived of our communities, or 10% of the population, is almost twice as high as the least deprived. Stroke incidence, so stroke is higher in some ethnic minority groups, and in lower socio-economic groups. So, for example, strokes occur 10 years younger in African and African Caribbean communities. So there's some examples of how inequalities actually play out in terms of life expectancy and outcomes. So let me give you a little bit of context of the long-term plan before I go on to describe how we have set about in it to try and play our part in addressing inequalities in healthcare. So the long-term plan, as you may recall, was requested by the Prime Minister in June of last year when she announced the funding settlement for NHS England for the next 5 years. So that funding announcement was significant because it is taking us over the next 5 years to a level of real-term growth in NHS funding that we have not seen over the last 7 or 8 years, back towards the norm in terms of real-term funding that we've seen over the 80 years of the NHS. And that increase in funding, that increase in money will make a difference because it means that we can invest in new services and in changing the way we deliver services. It's also important because it was a 5-year commitment. And as any of you know, as all of you know, planning for the future needs to be done on a basis that is long-term rather than short-term. And in 1-year funding settlements, it is often more difficult to plan strategic plans or to plan services that are lasting over a period of time. So the 5-year certainty allows us to do that. There are some things that it's not, and that's important to point out too. The funding settlement was for NHS England, and there are certain areas of healthcare and social care, as I said, that are not covered in that funding. So it's not a funding for settlement for Public Health England. And Public Health England and the work that the public health teams do is very important in this area. It's not a funding for Health Education England, and our staff need to be trained. We need a workforce, and that is dependent on that funding work stream. It's not a funding for capital, so it's a funding for revenue. So we still have to have the funding settlement for the buildings and infrastructure that we need to deliver aspects of the plan. And finally, and perhaps most importantly, it's not a funding for local government and social care. So those funding elements will come later in the comprehensive spending review. But it's really important that we think about those funding streams, and it's really important we work with our partners around those funding streams, because we cannot deliver all we want to deliver in the NHS unless those funding streams and those partners are able to do their bit too. And if you read the long-term plan, you will see that we very explicitly point that out. And of course, the long-term plan, as an aside, probably for the first time in the history of the NHS, is a plan written by the NHS for the government rather than a plan written by the government for the NHS. So it does allow us to state some of the things that we as the NHS would like to happen, need to happen in order to deliver what we want to deliver. The Prime Minister asked us to write a long-term plan. We set about over the summer and the autumn writing that long-term plan, and we engage with an awful lot of stakeholders, including, I'm sure, some of you in the room or some of your colleagues, to try and ensure that we wrote an inclusive plan that really addressed the issues that we anticipate over the next 5 to 10 years. And I think it landed reasonably well, actually. It's been well received. It was published at the beginning of January, and most commentators, most colleagues, most people think that it has addressed those areas that are important to address. And let me just pick out some of the key themes. It takes a couple of hours to read, I think, if you read it fast, but it's a good read and it's packed full of suggestions and ideas and maps for the future. So the first theme is a focus on particular disease areas, and I've mentioned one, cardiovascular disease. And the rationale for the disease areas that we picked was those disease areas where we know when we do international studies, where in fact independent experts do international comparisons, we are lagging behind in terms of outcomes, which is predominantly premature mortality, but is also morbidity. So in cardiovascular disease, in stroke, in respiratory lung disease, in child mortality, and in mental health, we are lagging behind in our outcomes compared to our international comparators. We're doing better than ever, actually, in those areas, but we are still not doing as well as we could. So that's the reason that there is a huge focus on those particular disease areas and a set of interventions, often around prevention, which we think will move the dial on that, so that at the next anniversary, the 80th anniversary of the NHS, those outcomes will be as good as or better than other healthcare economies that we compare ourselves with. The second theme in the long-term plan really echoes the Black Report, and that's on prevention. So it is true that a lot of prevention needs to be done through wider government, Public Health England and others, but that's not to say that NHS England and the NHS can't play its part in prevention. And one little example of that is on air pollution, which in this city is a growing issue. So 5% of all journeys that are undertaken during the week in England are NHS related. People going to hospital appointments, transport between NHS facilities. So if we could cut that back, if we could use technology, use different ways of working, smarter ways of working to reduce that travel, not only is it more convenient and better for our patients, but it will cut air pollution. And you may have seen in the Evening Standard yesterday, Sir David Sloman, my old boss at the Royal Free, who's now Regional Director for London, describing the work that he wants to see in London around reducing air pollution. So a big focus on prevention. Thirdly, a shift, again, echoing the Black Report, from hospital care to care in communities and care in primary care, which is the bedrock and always has been the bedrock of what we do in the NHS. And that, again, is aligned with a focus on prevention. And in fact, we put our money where our mouth is when it comes to the shift from hospitals to community and primary care, because we have explicitly stated that we will be disproportionately, or we will be giving additional funding to community and primary care over and above what we would have done if we had continued on our current path. That's not to say we're going to reduce spending in hospitals, because that care is important too, but we will put a real emphasis on primary and community care. And for us, again, technical but important, we have recently agreed a new GP contract, primary care contract, which sets out for general practice and community care what we would like to see happen over the 5 years. And that is putting in the resource and the workforce that will help us deal with the issues such as cardiovascular prevention that we have talked about in the long-term plan. So the third is the shift from hospital care to community care. The fourth theme is a theme on integrated care, which is a theme that we have really been pushing over the last couple of years. And that's really important, because that's our drive to join up healthcare, to join up healthcare services. So joining up hospital care with primary care, joining up social care with healthcare. Because from the public's perspective and from the perspective of a patient, healthcare is really disjointed at the moment, and people often go from pillar to post between healthcare, between social care, between community care, and that is particularly apparent, I think, in the populations that you serve and that you work with, and we need a much more seamless joining up, a much more seamless pathway of care for people who need to access healthcare. And then the final thing, which is last but by no means least, because it's the subject that we are discussing today, a real focus on inequalities. And what that actually means is that we think about inequalities right at the start of designing a strategy rather than as an afterthought. So those are the broad themes of the long-term plan, and there are a few specific ways in which the long-term plan will set about addressing that final theme of inequalities. So as I've just said, we were determined in developing the long-term plan that we baked in inequalities and an approach to inequalities right at the very start. So in all the interventions and all the plans, the plans within a plan that we have in disease areas, in the way the system works together, we asked the question right at the start of the long-term plan, how can we do this in a way that reduces that gap that we see in inequalities? So for instance, again, in the disease areas that I've been leading on in cardiovascular and stroke, how can we focus our interventions in that area, specifically in those communities that are the most deprived and where we see the biggest gap in outcomes? So again, a very specific example, atrial fibrillation, which is a irregular rhythm in the heart, which we know that when people develop it, they are at risk of developing a stroke because they form a clot in the heart, which gets thrown off into the arteries in the neck and causes the stroke. We know that by thinning the blood, we can prevent that, but we know that we need to target our identification of people with that abnormality in particularly deprived areas, and we need to target the intervention. So let's do that from the start rather than see afterwards whether it's worked as an afterthought. So we were challenged very strongly across all the work in the long-term plan to design in approaches to inequalities from the start. The second thing is we will be asking local healthcare economies, i.e. local communities, as part of that integrated care that I talked about, as they translate the long-term plan as it sits as a national strategy into a local strategy, to put an approach to inequalities in the heart of that translation. So we are asking them to describe in detail, locally, what they will be doing to reduce inequalities in their area. And that's going to be really important because, again, we don't want the emphasis on reducing inequalities to be lost in the translation from a written plan for the country down to how it is implemented locally. So that is work that you can get involved in because that is work that is only just starting and will occur over the next few months. And it's really important that the voice of those who work hardest in inequalities is heard in that debate. And then thirdly, there are some specific interventions that are focused at inequalities, and in particular, the area that you obviously are concerned about most, which is homelessness and rough sleeping. And there is a £30 million commitment in the long-term plan in this particular area to support, in many cases, schemes that are already being pursued locally or to develop new schemes. And we are not prescriptive in the long-term plan as to how that money should be spent, but we are asking local communities and local healthcare systems as part of their delivery plans to work out how they would like to access that funding and which schemes they could spend it on. So again, that is something, and Alex and I were talking about this the other week, something that I think you need to input into, and your voice needs to be heard in how we do that. So I'm optimistic because you have to be optimistic, and the long-term plan does give us some more resource over the next few years, and it does give us the opportunity to focus once again on inclusion, health and inequalities. And I hope you will be working with us as we translate that aspiration into the detail of how it's going to work. I'm just going to finish now before taking questions on some personal experiences. So in the year that I've been National Medical Director, I've had the privilege to see some of the work that's being done for the homeless and for our rough sleepers. Actually, the very, very first visit I made as National Medical Director was to the Passage, the St Vincent Centre, which is 2 or 3 stops down the district line, just outside Westminster Cathedral. And in my first week as National Medical Director, I went there, spent some time with the people there, with the staff. And what really impressed me in that particular centre was that the way that healthcare has been fully integrated into the work of the centre. So access to healthcare is made very, very easy because it is on-site and available. Only a few weeks ago, I was in Manchester and I went to visit a dental practice which had been established for the homeless and rough sleepers by an inspirational dentist, Ben Atkins. And with the support of local commissioners and actually with not an awful lot of funding, but with a huge amount of passion, a huge amount of determination to put something back into the community, and some inspirational ideas. Ben and his team have set up a dental practice specifically for the homeless in Manchester. And what I remember about that visit is Ben describing what it meant to put the smile back on people's faces. So his view, his goal was in many ways a simple one, but by addressing dental health, by actually even aesthetic dentistry, i.e. making teeth look better, would give people back a bit of confidence, because in their interactions and their relationships, in getting jobs, getting work, accessing services, the ability to smile and the ability to project yourself is one little bit of what brings confidence back. And that really was an inspirational visit, because that was the determination of a set of people who really wanted to make a difference. And then my final personal experience predates my time as National Medical Director, because when I was Medical Director at the Royal Free, Alex and the late Aidan Halligan, a good friend of mine, came to see me and described the scheme that Pathway scheme at UCLH, University College London Hospitals, just down the road, and asked whether we would put in place the same scheme at the Royal Free. I can't remember how many years ago that was, but it was probably 5 or 6 actually. And we did put that scheme in place at the Royal Free, and it made a difference. For a number of reasons, it wasn't sustained, but it did allow me to see the great work that Alex and Aidan had done. And Alex and I met recently. I know that work is now extended beyond its original schemes, and actually I'm delighted that he told me that they are going back into the Royal Free and in collaboration with UCLH and the Whittington, looking to restart that scheme. So I have been really impressed over the years that I've known Alex and as I say, Aidan, their determination and their inspiration in making a difference to our homeless citizens, our colleagues, community. And I'd like to say thank you, because it's really made a difference. So I'm going to end there. I think I've said a little bit about next steps for the long-term plan. And I end again with a call to everybody in the room that don't let this be the work of somebody else. Let this be the work that you're involved in, and back in your healthcare communities. Find out how you are translating the opportunity of the next 5 or 10 years locally, and make sure that you get involved and you influence your local healthcare policymakers. Thank you.
Stephen, something that was mentioned yesterday a number of times was in the Homeless Reduction Act. GPs are excluded from the duty to refer. Will the NHS and NHS England petition the government to include GPs in that process?
Well, I can't answer that specifically, but I will go away and take that back to NHS England. But I think one of the things I could say in primary care, which I talked about, was we are investing more in primary care, and we are building up the teams that are available in primary care. So social prescribers are a key part of the teams in primary care, and social prescribing is a term that that has become commonplace, but really what it describes, in my mind, is going beyond an approach to pure healthcare and medical care into an approach that is much more holistic. And there are great examples of that. The one that we often use is Bromley by Bow out in East London, and Sam Everington's practice, where if you go there, and I would urge you to visit, you won't visit a healthcare centre, you will visit a community centre that happens to have some healthcare professionals in it. And we want much, much more of that. Another visit that I went on last year was down to Frome in Wiltshire. I don't know if anybody's been down there, but the local primary care, the GP practices down there, have set about building a network of what they call connectors with their local community, which is a community of people, an awful lot of people in the community there, who are able to provide expertise and help to their fellow citizens beyond what is a medical model, i.e. where you need to go to get assistance. So I think there is an awful lot that primary care can do, and with those extended teams in primary care, I am absolutely sure that there will be the opportunity to do more work for the most deprived in the community, and in particular the homeless and rough sleepers.
I was struck yesterday when Kate Pickett was talking. She was talking about the need to shift from, in a sense, individual pathology, the notion of changing people's lifestyles, to something which was much more of a whole system approach. I've often thought one of the problems for the NHS is that it talks about putting patients at the centre of the system, when actually there's no room at the centre of the system because it's full of doctors. And they control the model, they control the idea of health that is entirely built around the notion of individual pathology, disease, and that's precisely what supports their status. So in the end, there's a much bigger problem, isn't there? And you mentioned it, that actually half of the things that you're trying to tackle, the causes of them, are out with the scope of the NHS. So actually, there's a sense in which whatever you do will be tinkering at the edges, whether it's community centres or whatever, unless the NHS can start to work on a kind of system basis which tackles inequality. So I just wonder whether you discuss that and how you think about the way in which you can change the system, in a sense, to move doctors out of the middle of it and put inequality into the centre.
Yeah, so I think there's an awful lot in that question. And I think, whereas it is always going to be the case and should be the case that part of the role of the doctor and the healthcare professional is that skill of that one-to-one interaction, because that is really important. It's really important that I can sit down with you as a patient,
absolutely,
and have a discussion about you. I think there's a number of other things that are important. One is that it is not just a conversation about pathology and disease and physical health. Yeah. So I'm a kidney doctor, and I spent a lot of my time before I stopped practicing managing and looking after people with long-term kidney conditions on dialysis, and latterly people who'd had kidney transplants. And to be honest, in my outpatient clinics, I would very often be discussing housing and education and welfare, and sometimes not discussing immunosuppressive drugs and how you manage the transplant, because actually for the transplant patients I looked after, what was important was getting back to work. Yeah. What was important was getting back to a normal life. And what I wanted to do and could do, but to a limited extent, was help in what they needed to do in their interactions with social care or interactions with employers to get back to that life. So writing a letter to an employer around what somebody could do is just as important as physical health. And then the second thing, just before you want to open it up, is I do think that doctors and healthcare professionals, we need to do more to prepare them for working with populations, rather than just working. So the paradigm of medicine, in a way, is still around that individual interaction. And one of the things that I say is that often say is that the doctors of the future, the professionals of the future, are much more going to have to work in teams, and are much more going to have a holistic view around how you improve populations populations rather than individuals. Yeah. And that doesn't mean it's either or. It needs to be both and. But we need to prepare people to do that and give them a set of skills to do that. So the truth is, I probably make more difference now to many more people in this job than I ever did as a doctor who sat down individually, because I have the ability to influence things that will make a huge difference.
Thank you. There was a question over there yesterday that I asked I thought you were there in the corner. Would you like to re-ask the question that I postponed from yesterday?
Hi, I'm Maggie Kirk, GP in Bournemouth. I'm in an area where the recent homeless health needs audit showed significantly worse figures for people who are homeless in our county, across all the indices pretty much, and that included showing that only 2/3 of homeless people there were registered with a GP. In recent years, our funding from the CCG has actually been reduced. Our practice holds a contract for producing GP specialist homeless services, and we've seen a reduction in funding in recent years. At the same time, obviously, as homeless numbers have increased. So one of the things I've been involved in has been developing a mobile GP service from a bus for rough sleepers in the city centre, and we've enabled over 300 consultations with patients in the last 18 months from that. So in this time, the council has also benefited from almost £500,000 in the MHCLG funding, and that's been fantastic. It has funded the development of all sorts of psychosocial interventions, but whilst that's been going on, I've been in a conversation ongoing with the head of primary care in the CCG and the commissioners, requesting a matched increase to meet the health requirements. So my concern at the moment is that there hasn't been that increase and we're struggling. And I'd just like to ask you, it's really encouraging to hear what you're saying about us all getting involved, and I'm trying my best, but how should I work with our CCG and maybe public health, any other groups that you can suggest, so that we can provide our GP services without having to rely upon charitable donations?
Thank you.
So really, really good question, and I think it talks to some of the things I said in my talk. In that, firstly, increased funding is coming in April, and I know it's not a huge increase, but it is an increase nevertheless, and it will be finding its way into CCG budgets. And we have reformulated the allocation. I can't give you off the top of my head what it means down the south coast, but we have started to ensure even more that the CCG budgets are aligned to deprivation. So that is a positive move on behalf of NHS England to ensure that funding goes to our most deprived areas. So that's the first thing. Second thing is I have been down and visited general practice down in Bournemouth, and I'd love to come down and visit again. So the integrated care systems that are being developed and down in Dorset is a great example, is where we increasingly want the work to be done that I've been describing. So I'm sure you are having conversations with the integrated care system, of which the CCG will be part. But I think really having that conversation with a broader set of people than just the CCG, I think, is really important. And that's why my call at the end was, as these new systems, and in a sense we hate talking about systems and architecture, but it is nevertheless what delivers these services and what supports them. Getting involved at the start of that and setting the agenda, I think, is really important. So I go back to what I said at the end. I think there's a moment in time where there's an opportunity to get things on the agenda from the start. And perseverance is great, but I'd love to come down and see what you're doing.
I would copy Stephen into all your emails to the CCG. That'll get them going. I've got a question there, and I've got a question here, and a question there, and then unfortunately that will probably be it. But there.
Hi, I'm Liz Bates. I'm a GP, NHS GP in Birmingham, and I also work with Doctors of the World UK. In my NHS work, I work with some of the most excluded people in society. That's refused asylum seekers and those with irregular immigration status. They've got great access to primary care where I work, but what I can't do is send them to secondary care because of the NHS charging regulations many of the time. What's been done within NHS England to challenge this frankly insane and unworkable and complex set of regulations that are excluding a large number of people from receiving the care they need? And these are people who quite often come back to the NHS when we manage to sort out their asylum status and reopen their asylum claims. And in the meantime, but in that sort of place where they're in the pit and they've been refused asylum, we can't do anything for them other than provide primary care.
And I know it's a difficult area, and it's an area that when I was managing dialysis units, I saw too, because we certainly had patients on dialysis who were asylum seekers or were refugees or had recently come from other countries. It's a conversation across government, as you know, so it's one that we can influence and we can talk through. I can't give you the specifics, but I'm happy again to take it away and get the latest update. Obviously, it's clear as doctors, as professionals, we have a duty to care for illness and patients when we see, and in my book that always trends everything, but I know it's a complex set of rules, so can't give you the specifics, but yes, I will go and again check.
Thanks for the question.
Tim Robson, I'm the current clinical lead of the pathway team at UCLH, which got referenced in your plan.
It did.
So that was the world's first pathway homeless healthcare team set up by Aidan, as you say, and it's 10 years. We're talking of anniversaries, 30 years since Black, 10 years since that. And very welcome to your comments and your support, and I've never been in a report like that before, my team, so that was quite something. As you mentioned, though, we tried to have a pathway team at the Royal Free and got a little way, and then not far. We've got around 10 now. If at the present rate of expansion, it would take us 25 years to get to the rest of the 140 hospitals that probably need it across the UK. And it's mental health as well. We've got Zana Khan here, who's produced papers to show that this sort of approach would work in a mental health setup. So it would be great to have your reassurance, but also a bit more actual concrete support, where possible, as to how we can roll that out rather quicker. You know, and that's one of the things that's facing Pathway at the moment. There's people here working on that, but we want this to work. We want to actually be able to roll these things out in the next few years, not over 25.
Clearly, that plays into your prevention agenda.
Yes, and of course, well, we will have had these conversations in the past, and I'm sure you have got much further on. So to an extent, demonstrating the benefit, and really, you now have the 10 years worth of work to demonstrate the benefit, both in terms of the health benefits, but also I think that you should be able to demonstrate an economic benefit as well, because cost avoidance in preventing people having to stay for long periods in a hospital bed when they don't need to will have a cost benefit. So my experience of directors of finance of NHS trusts is a really robust evidence base on an economic benefit. It's not that they don't care about patients, of course they do, and they're not heartless, but they nevertheless also have to balance the books. And I imagine, it's not something I think we discussed when we met, you will have built up a robust evidence base now, and I think using that really strongly in your cases is, in my experience, the thing that often pushes it through.
Thank you. Well, if they are heartless, at least they're in the right place. We're going to have to, unfortunately, we've run into Kate's time and the next session's time. Not Kate, sorry, that was yesterday's speaker. Into Professor Ensign's time. So thank you very much indeed, Stephen.
Delighted to be here.
If you'd show your appreciation in the traditional manner.